So I would like to discuss one part of my practice, which is accelerated treatments thanks to piezocision. So what is piezocision? Earlier today, we talked about corticotomies. About 15 years ago, we started, the Wilco and Ferguson brothers started this technique in the United States. It was pretty aggressive. You would spend between 2 and 2.5 hours in the surgery room with your patients. And obviously the idea was to use the same sort of technique while having an easier workflow and a minimal follow-up for patients and an outcome which was of the same quality. So we wanted to have a clinical result that would be similar to those of the alveolar bone corticotomies, while significantly decreasing the operating cost and therefore the cost of operation per patient. And we want to also reduce the post-operative discomfort for the patient. The technique was published for the first time in 2009, so it has been around for a while. The objective is to get the same result as with corticotomies. So minor invasive technique, you do not need to elevate a flap, you do not need to damage the papilla. We use a piezotomy to incise the tissues, very light postoperative discomfort. The patient can go back to work on the same day, and if necessary, you can combine with bone or gingival grafts without elevating a full thickness flap. So those are the different steps. So you have a certain quantity of a touch gingiva, so a local anesthetic, then a short incision, in the gingiva with a piezotomy, and then we're going to penetrate the cortical bone very superficially, but then we're going to extend that incision in the direction of the apex. So we start about 2 to 3 millimeters from the bone crust in order not to damage the crust, and then we're going to extend those incisions as high as we can. I will provide with more explanation on that in a moment. That's the more technical side of it. But anyway, the piezotomy is just penetrating the cortical bone on a few millimeters. We stop when we reach the bone, and then we extend the incision in the direction of the roots. Same thing on the mandible, if necessary. And if necessary, you can create a tunnel in which you're going to insert a graft, be it a bone graft or a gingival graft. We don't do that on a systematic basis in our clinic. Most of the time, we only do with incision. So this is a patient at the end of the treatment surgery. So no stitches on the smaller incision, and then we will be seeing this patient for recalls every second week. When you have less attached gingiva, sometimes you need to extend the incision until the 3 gingiva, and then in such a case, you need, of course, to create stitches, because you want the cortical bone incision as high as possible to get the entire effect all around the root. Now, this is the first patient that we treated and published. It was a pretty simple case, class 1 with a tendency for class 2. There was an imbalance, dento-alveolar imbalance, plus a deep bite. We had a nice effect on treatment time for 4 months and 1 week. Back then, we didn't use self-ligating brackets, but you do see clinically in the very first weeks post-surgery. So what we do basically is that we bond the brackets so that the cell starts working. Then 6 weeks after, we perform the piezo incisions. And then about 6 weeks post-surgery, you do have this acceleration. And you do see that there is a stimulation. And so there's a phase during which you're going to get a very quick, swift movement. So there's a window here during which you're going to recall the patient at a very close intervals in order to activate all those brackets and really speed up the entire treatment. So this is our patient before and after. Now, experimental studies. This is a more technical parenthesis for you to better understand what happens from a biological point of view. Whatever the type of incision, whether you talk about corticotomies or osteoperforations that were mentioned previously, or piezo incisions, the biology is the same. Back then, corticotomies has been around for quite a while, for about 60 to 70 years. They have been published, and their impact has been published. Well, initially, we thought that it was a mechanical concept. We thought that those were reduced osteotomies, whereby you were displacing fragments. But this philosophy is no longer again in fashion, and the incisions, whatever the type, are going to create an increase in the bone turnover, and they're going to be favorable to bone remodeling. Concretely, you have a regional phenomenon of acceleration. This was very well explained at the end of the 80s by Frost. He was an orthopedic surgeon, and he said that any wound in the bone is going to increase the turnover, the bone turnover. They calculated back then that you have a 5-fold turnover increase around such a lesion. And what you see here is the corticotomy incision, and you see that in the close vicinity of the incision, it's pretty local. It doesn't extend to the contralateral side, but around the site, you do have an increase in the bone turnover. Now, the increase in bone turnover, whether it is induced by drugs or mechanical drug or mechanical solution, you're going to increase teeth movement. So this was demonstrated in that study. And so the rationale behind by Wilco and Ferguson is that those incisions do create a local acceleration phenomenon, and in turn, this phenomenon is going to increase the bone remodeling in the close vicinity, and it's going to be favorable to teeth movement. Now, this was a study that we published in 2004, where we quantified the modeling and remodeling after alveolar decortication, and you do see in the weeks that follow there's a decortication, and then the bone changes in the way it is composed, and again this supports teeth movement. You do have a bone apposition in the close vicinity. So after 3 weeks, you have a 3-fold increase of the catabolic effect plus osteoplastic. So we could demonstrate that regionally in the close vicinity of corticotomy. So at the end of the day, what we want to create, we create a bone with the same type of bulk, volume, but there's a remodeling which is a lot quicker. And this is why I was mentioning how important it is to extend those incisions as high as possible. And so when you perform piezo incision, you have to create those punctures on the entire length of the root. And so the more aggression you have, somehow you're going to really trigger that inflammation. And so you need to have a certain number of points in order to increase that bone remodeling. There are also a number of papers where they assess the combined effect of corticotomies and orthodontic treatment. And in one of our papers, we measured what happened in the days and weeks that follow. So after corticotomies and orthodontic treatment. And you do see that there's a correlation. So you do have a correlation between resorption and then bone remodeling and orthodontic movement. There's a study that was published in the European Journal. And we demonstrated in that study that between a group, or between an area with piezo incision, and on the other hand, piezo incision plus orthodontic treatment, you do see synergies in effects of both measures. So after a couple of weeks, you resume, you get back to the same sort of values that you had before, while you have an extended, prolonged effect on the side where you have piezo incision plus orthodontic treatment. So clinically, you do see that after 6 to 7 months, the effect tends to plateau, and so you have that window, as I explained before, during which you should move your teeth as much as you can. Now, as a conclusion on the biologic effect of the piezo incisions on orthodontic treatment, of course, the hypothesis is that there is a biologic rationale. We no longer do an en bloc movement. We do see that we have about the same type of results, whatever, irrespective of the surgical technique. Of course, the more aggressive the technique, the better the effect. Of course, it's going to depend on the original bone density. And we do have a very, well, you have a temporary effect of corticotomies very early. It doesn't seem that there is any bone resorptions to report. Now, this is nothing else or nothing less than tissue engineering, which is very localized, and the effects are very short-lived. Of course, with that in mind, you need to think whether you want to apply that on both arches, whether you want to apply it only on the posterior aspect, you want to apply it from 7 to 7. Again, the fact that you only have incisions on the buccal side may be beneficial for a number of patients. Now I'm going to show you some of my cases. We're going to start with more conventional cases without extractions. Then we will discuss extraction cases, surgical cases, combined with orthodontic surgery, where piezo is very beneficial, especially in adults, because it's really reducing treatment time. And then we're going to discuss combined treatment after prosthesis or after grafts. Now, this is a patient. She was bonded in January this year. There's a slight anterior open void. There is an imbalance. There is a slight drain to class 3 on the right and class 1 on the right. Nothing too severe. We started a complete piezo incision. So she had a pretty narrow smile. The buccal corridors were rather, well, you could see the buccal corridors very much. And we just wanted to increase the transversal direction or dimension. And what we wanted to do was really to get the most of that bone modeling. So operating time was comprised between 30 and 40 minutes. So this is a typical timeline. So we bonded when we waited for 7 to 14 days. When we go for piezo, generally under local anesthetics, either the periodontist or the oral surgeon is going to do that. Then for a period of time, 4 to 7 months, you have this period of wrap, of bone remodeling, and that's really the moment when you want to recall your patient every 15 days. So obviously, it's not a very good idea to do piezo right before the summer vacation, because you know that your patient's not going to come to your practice, and then you're just going to lose all benefits. So it's better to really schedule such a surgery when you know that your patient is going to recall on a regular basis. So this is 2 weeks after surgery. You have an eventful healing. But generally speaking, this is, as I said, very uneventful. So this is 8 weeks. We have a 0.18 copper night tie. We have a very nice leveling of the arch. 12 weeks, we try to engage rectangular wires as quick as possible. So this is an 18 to 25. We do have a very nice expansion in the arch shape. 8 weeks. We still do have a slight open bite. We're going to work with vertical elastics on the cuspids. And this is 20 weeks in 5 months. So we do see a closing. You do have a very nice functional result, class 1 on the right-hand side. We do see the midlines that are starting to align. And eventually we reach that stage where the effect sort of wears off. Now, of course, you anticipate that because this is the moment when you start your finishing phase. You talk, maybe you have to rebond your attachments. But at that stage, as I said, we start with the finishing phase. You do have contacts in between the canines. The brackets were not positioned in the best position from a visual point of view. And then we start finishing. 7 months in, the case is stabilized and virtually finished. Most of the time when I reach that stage, I wait for 1.5 months and I stabilize with vertical elastics, and then I debond. And then I bond my retention. So it was a case which was finished in 8 weeks, and I'm sorry, in 8 months and 2 weeks.
Regarding the corridor, we have expansion. It's very important that we go to the side, because if we limit ourselves to the area where we have crowding, we would end up with a few problems there.
Diminution du temps de traitement, nous cliniquement on la retrouve de façon relativement consistante.
Here we have something rather consistent. Here we have Carole Charavet's study from the Leuven University. She calculated a decrease post-corticotomy, a decrease in the treatment time, 42%. No variations in the periodontal parameters, no increase in root resorption. However, she did observe, following the scars, that there were the surgery, that there were scars in 50% of the cases. More in patients with ethnic pigmented skin, but if the gingival difference, at least we can tell if the gingival, if there is a high lip line, we tell the patient that there will be a small scar, but it's very thin. No difference in the pain. We don't give the patients anything except ibuprofen, doliprane, or paracetamol. No patient dissatisfaction, and patient satisfaction is actually increased in the piezo group. We found that there was a decrease in the treatment duration by half approximately, especially in the non-extraction cases. And combined with Genius, we have advantages. First of all, we save time in the past that we already have in the passive systems. We have slots with good torque expression, rotation control is improved, all of which is combined with a biological environment and cooperative patients. The finishing time comes faster and the treatment time is shorter. And combining the two systems is quite clever. Here we have tilted teeth in all the sectors, lots of crowding, so we need to develop the transversal area by piezocision. We can make wider incisions on the lateral parts. Look here at the treatment, slightly longer, 1 year for this correction, class 2, division 2 initially. Here we see a transverse development of the arch, and the corridors are improved, and we use piezo surgery from 7 to 7. 7 arch wires were used. We try to engage insert the wires as quickly as possible, and then we move on to the finishing phases. And again, we have similar results. Now, it's not really operator dependent. If you start this technique, you need to talk to the periodontologist and the surgeon, and you tell them not to make a 3 millimeter opening with just one 3 millimeter line. You have to extend. The opening here, when you make the incision, is very small, but underneath, the piezotome is going to widen the line to have a good effect. Otherwise, it won't be any clinical favorable effect. Arch wire change. We engage the rectangular arch wires as quickly as possible to make sure that we're still in the acceleration phase, the phase that is favorable when the torques are engaged. Here we have a slightly more severe case with a slight improvement, a transverse improvement in the smile aesthetics. We have already seen the slide. It's just a reminder of the advantages of the Genius system. And regarding tissue engineering, we have the two combined elements providing more control and ease of use of both for the surgeon, for the patient. Socially speaking, it's better for the patient, really, because we don't have all the disadvantages that we had at the time when we performed corticotomies. Here we have many advantages. Now, extraction cases. Unless you want to use sliding mechanisms, but here if you want to close spaces, we said earlier that the technique is located and the very, very limited in terms of location, and the results are temporary. If you only do one line, mesial and distal from the tooth, there will be no effect regarding the socket. Well, there is a small effect generated by the tooth extraction, but the biological effect is not sufficient. And in these cases, and this is what we showed earlier, it's absolutely essential that you make the incisions around the extraction socket in order to increase the bone turnover around the root. When you retract a caspid, you have to extend the incision upwards towards the molar to cause a demineralization effect all around the tooth where it's going to move. And especially when there is a high expectation from the patient who wants to close the treatment faster. When you start closing the space, if the space is not closed after 4 or 6 months, not only do we no longer have an acceleration effect, but we even have a slight increase in the bone density in the area. So in some cases, if there is still a lot of residual space, we perform very localized small incisions all around the residual space. You can do it in the clinic. It's only a local anesthesia. You do a couple of incisions. In this case here, the treatment is in progress, and we have metal and crystal brackets and on the lower arch, extractions, bonding. After 2 months, we see the spaces are closing. We have springs, coils before we start looking after the lateral incisor. We have one sector closing faster on one side, and then between the 5th and the 8th month, things are slowing down. But in this particular patient, we did not redo the incisions because we thought that the speed was sufficient. However, we could have done a few incisions after the 5th month, because look at the residual space. Here we have essential movements after the greatest movements after 3-4 months. We engage the lateral incisor. We reverse the attachment to generate more torque. So because there is a limited time and space, I often do small incisions around the residual space, and I warn the patient initially, and I tell him that otherwise it's going to be about 1 year if we don't do extractions. With piezo, we can gain time. This patient has bimaxillary protrusion. We decided to extract 4 molars. She had an open bite. We worked on her tongue with a physiotherapist. We extracted the premolars. We wanted to correct the profile. After 4 months, we already have a marked improvement in the incisor position. And after 1 year, we have closed the spaces, and her incisors are vertical again, and we see the improved profile. Usually extractions before 12 to 14 months, non-extractions, sometime between 5 and 6 months, we have the greatest effect, and then it slows down. Orthosurgical treatments. For me, piezocision here is very useful, because we can decompensate the arch, level the arch, and we don't need to worry about the arch position. We can do this faster by increasing bone per turnover. So the piezo is really there to shorten the decompensation pre-surgical phase. In those patients The incisions are made by the surgeon who will subsequently do the surgery. So we have a surgical preparation time 4 to 6 months before osteotomy. In this case, the patient had been treated some time back. She had a class 2, and the surgeon had decided to go for mandibular advancement, piezocision, complete decompensation, mandibular advancement, and then finishing phases. Here, the treatment time is approximately 10 months. Surgery was performed by Dominique Defresne, and we see a marked improvement in the patient's profile. In 10 months with socially is quite acceptable for patients, because very often that is the obstacle, and very often patients want a treatment that is not too visible. That's why aligners are very fashionable. The social relationships are very, very important. They clearly are an obstacle for some patients who refrain from undergoing treatment. Another patient who had bridge work in her mouth, she had deep bite, a class 2. Again, orthodontic preparation, pre-surgical preparation and piezocision from 7 to 7. We manage the deep bite, the alignment. This is performed in 5 months. She's ready. And then we perform mandibular advancement. The provisional crown restoration is placed, and the total duration is 8 months and a half, from beginning to end. So we can do this while complying with our patients' expectations. Dominique Defresne did the surgery. Finally, the contribution made by piezocision when it is combined with other techniques. Take, for instance, tissue defect, soft tissue or hard tissue. When you want to combine orthodontic treatment with other techniques, or when you want to achieve pre-implant placement orthodontic treatment, often the dentist does not want to address the patient to you for a very long time. They simply address them to you for a very specific action. So we have the capacity to work in very short times. The prosthetic restoration is no longer integrated in the orthodontic treatment, but rather the other way around. It's the orthodontic treatment that finds its place within the implant treatment. So how do we manage the graft? With piezo, we can perform a deep connective tissue graft. Here we lift the flap, and we can do a connective tissue graft. Very easy to do for the surgeon in one single appointment, so it's all done at the same time. When there is a bone defect, either we use the tunnel technique, which was shown earlier, which is a bit more operator depending, or else we can do something that is akin to corticotomy, but it's a very localized graft. Here we are talking about hard tissue grafts, and we can do this when there is either edema or fenestration. Flap technique described earlier. We don't raise a tunnel, we don't raise a flap. We use the tunnel technique, so 3 skin incisions. We elevate the periosteum. We then perform the small cortical incisions. We place the graft usually this way, or by filling a syringe and injecting. And then we suture in place. The periosteum acts as a membrane. No need to add a membrane. 3 sutures here to hold everything in place. This is a case when the patient was treated before implants were placed in the patient's mouth, and the implants were placed at the mandible. At this stage, we wonder whether we can manage the lower arch alignment during the integration phase. And that's the whole point here. Piezo, after 3 weeks and 3 months and 2 weeks, we don't have anything else to manage. And it's really finding its place within the whole phase. And a few weeks later, the patient was given her complete upper arch rehabilitation and the posterior lower arch rehabilitation. Complications. The surgery itself is not tricky. It's not corticotomy. There are far less complications and dangers. Not something that you have to do quickly without any X-rays. So you have to be on the safe side, at least have some X-rays, check for the root location, and if needed, lift a flap so that you see what you're doing. You may have bony defect, a tooth defect, or tissue, soft tissue defects. This picture was sent to us by a dental surgeon. The incision went far too low, and in order to fix this, well, I'm not sure that they will ever be able to fix the problem. So make sure that you limit yourself to the attached gingiva, or stay away from the tooth, stay away from the crest. Here, look at the mistake. This is a big mistake. They simply rushed through the surgery. They just went too fast, and 3 months later, no healing. Inflammation is still present. Here, the surgery was performed. And what do we see? What do we have? The incisions were performed above the roots. So I don't know how this was done, really, because, I mean, the advantage with piezo instruments is that you feel what you're doing. If you're trying to go through the alveolar bone, you can feel it. If you touch the root, you can feel it. And quite clearly here, there was a perforation. The orthodontist was able to manage the problem. They lifted the flap, they raised the flap, but the surgery must be adequately planned with x-rays before the surgery. And if you feel that you're too close to the roots of the bone, if you're not feeling safe, then just refrain from doing it. If you feel like you have to raise the flap, then do so. Be on the safe side. Because here we have a serious complication. Fortunately, it's the only case that I have ever encountered with similar complications. But I believe it is important that we show the complications. In conclusion, piezocision. For me, it belongs to our armamentarium for adult patients, because it will help you comply with the patient's expectations of shorter treatment times. It's not non-invasive, it's minimally invasive. Post-op care is limited to a few days, very little swelling. You can do bone graft, soft tissue graft. Orthodontic treatment is faster, cut in two, and it also widens the possibility of treatment. And you can reinforce the periodontal tissues if needed, and you could prevent resensions during expansion. And it's a very versatile technique. Thank you very much for your attention.